Have you started it?
Yes, I've started recording.
Yes.
Would you like me to share the program now, Clive?
Yes, please. Can I just say welcome, everyone. It's a tight program this evening, so I'm going to try and kick us off. I think we're expecting a good few more people, but no doubt they'll come in due course. So welcome. I'm Clive Saunders. I'm a couple of things. I'm the Inclusion and Involvement Lead for HPFT, but I'm also the chair of the Watford African Caribbean Association. And tonight, as it happens, I'm wearing both of those hats. We're here tonight because actually I was approached by some colleagues within HPFT who were concerned about accessing or the access of the African and Caribbean community to services. And in our conversation, I think we determined that it would be an excellent time. Sorry. It would be an excellent time to actually have this event during Black History Month to engage with the wider community around this important issue. We originally started thinking about Watford, but then we soon realized that actually we needed to look at this across the county. So just in relation, sorry, can I ask people to mute their microphones, please? The Watford African Caribbean Association, who are one of the partners in this venture, along with HPFT and also Viewpoint, and we're all here. The association itself is now 45 years old. We're a membership organization, and if any of you are interested in joining, membership is actually free, and we'll put the link in the chat later on. As far as this evening is concerned, you will be aware from your invitation that this event is around mental health and well-being of the African and Caribbean communities in the county. Our aim is really to try and see how we can contribute to bringing about better well-being for that community. So tonight we are wanting to share some information around this issue regarding the county. We want to kind of think about some of the experiences that people have had, and we also want to consider what needs to change as far as this goes. So I think you can see from the program what we're aiming to cover this evening. So we have a number of speakers, and the way we're aiming to proceed is that we're going to initially listen to our speakers. We're then going to have a brief Q&A. Then we're actually wanting to hear your voices through a little bit of a group exercise. And then we're going to kind of reflect on where we go from here. I'm actually not going to say a great deal more now, other than to say how we're going to proceed. So unless there are any immediate, sorry, just to say, as we go along, there may be questions that you might have. We do have a chat function with this, so do put your questions in the chat, and we will pick them up in the Q&A. Recognize it's a short period of time, so there may be some questions, and we'll try and go back to those later on. During the Q&A itself, it may be if you do really want to ask a question, then do put your hand up as well. We have that option there. So that's by way of background to where we're at now. So I think we can probably stop sharing the program now, Adrian. And I can see now we've got just under 30 people on this call. So without further ado, I'm actually going to call on our first speaker, who is someone who I suspect is probably better known to me over a longer period of time than most of you, since our roots go back to the Midlands when we were both, I think, had some connections up in Wolverhampton. So I'm going to hand you over to Patrick Vernon now to speak to you and to share some thoughts around some of the national picture. As it happens, Patrick is also one of our executive director at HPFT. So over to you, Patrick.
Yeah, hi there. Hi, Clive, and good evening to everyone. It's great to be here, talk about the issues around mental health, which is quite big. I'm just going to I've been asked to give an overview, and then you're going to kind of drill down locally. I mean, obviously, I'm on the board of the trust as well, and obviously, I'm also kind of keen and concerned to make sure that we are delivering mental health services meeting the needs of everyone in Hertfordshire, particularly Black and minoritized communities. But I think in terms of the whole stuff around mental health, there's something old, something new, something borrowed, something blue. So where should I start? Well, on one level, I think the pandemic has done one thing. It's a lot of people had to go through social isolation. A lot of people lost loved ones, as a result of people dying connected with COVID. And it's kind of brought mental health as a major topical conversation in British society. Issues about young people around mental health, and from our own services as a trust, we're trying to do the best we can to help with young camp services, and we know we have to get extra beds because there is a lot of young people now. Maybe this was happening before lockdown, but definitely lockdown has further intensified the whole issue around young people mental health. That's a big issue. But I think what I see as a result of the pandemic, and obviously the big issue around grief and loss, major issue, is the whole of the country had to go through some degree of social isolation, which is no different and very similar to a lot of people who go through mental health crisis and they've been in and out of the mental health system where it's a kind of imposed isolation. And I think people start to appreciate, because people have went through their own experience of anxiety, depression during the lockdown, uncertainty, fear. It's the kind of things that people have experienced in the system too. So I think it's given more of an appreciation, I think, around people around mental health, definitely. And I hope that this influences better funding for mental health services. I hope it will influence better ways that we deliver mental health services. Because one thing that was quite clear, that people had to work in a very agile way around respond to need as well. But in the context where it's Black History Month, mental health is even more pertinent, and obviously we had World Mental Health Day over the weekend. It's still more pertinent. I mean, I've worked in mental health working in NHS as a senior manager, as a campaigner, activist running health charities, and now being on the NED and been involved in other stuff. And even though there have been improvements in different aspects of mental health care and delivery and types of interventions over the last 20, 30 years, community mental health teams, new medication, which compared to the old medication that was used back in the 80s and 90s, where heavy dosage was used, it's slightly different. So there's better medication plans, new ways of people engaging. It still doesn't answer the big fundamental question: why is it that there's still a significant number of Black people, and increasingly other people from other minority communities, getting sucked into the mental health system? That hasn't changed, definitely for Black people, in the last 30, 40 years. And sort of, yes, and the outcomes, if you measure the outcomes, they haven't been that significant, I think, overall. I mean, and that doesn't take away individual cases of recovery where people have recovered and some people have been able to build their lives again. But I live in Hackney, and I walk around Hackney, and I see more and more people with psychosis around Hackney, coupled with increasing number of people being homeless at the same time. So to me, I ask these questions: why is it? If we're able to have the latest, if we can get basically 2/3 of the population of Britain to have the first jab or the vaccine, and if we're able to do lots of furlough and give billions and trillions to help businesses stay afloat, why haven't we got that same level of energy around tackling some of these issues around mental health? I mean, and I can go into more detail about that. I was heavily involved, as you know, around the whole stuff around the Windrush scandal. Today, there are thousands of people, I'd say about at least 10, 15,000 people, who have gone through the hostile environment policy, been affected by the Windrush scandal, not receiving any counselling, no therapeutic interventions as support as a result of the hostile environment policy, as in terms of the Windrush scandal. And I'll tell you that because I work closely with a number of the survivors. I call them survivors of the scandal. They're all experiencing post-traumatic stress. They're all having sleep deprivation, anxiety, and yet there's been no recognition at a local level where they live, or even at a national level, about their needs. And over 2 young people have died in the UK who've connected with Windrush, all stress related, by the way. So the stress on their mental health now has an impact on their physical body. And there's been a lot of research work done in America, particularly done by David Williams, who's now on the board of the Race Observatory, to demonstrate that microaggressions and structured racism has an impact on your physical health and your mental health. This kind of thinking, we need to stop. My challenge now is we need to have this kind of thinking in how we do research work, policy development and service delivery. Because one of the key things that that NHS services are not designed for is community trauma. And if you look at the victims of the Windrush scandal, people at Grenfell, and other aspects of community trauma, we're not dealing with those big issues, which means that people are treated individually. They go through a crisis situation. They're treated under the usual Section 136 of the Mental Health Act, and they're treated as an individual without looking at the wider issues. So there's lots of systemic issues that needs to be explored. I think the murder of George Floyd triggered. I don't know how you felt when he was murdered. I mean, it was nothing new, because I can think of Clive. You can remember back in Wolverhampton, the murder of Clinton McKerbin. Very similar circumstances to George Floyd. That was about 30 odd years ago. But the murder of George Floyd and the resurgence of Black Lives Matter, lots of black people around the world were re-traumatized, having experiences of, from childhood, how they were treated in school, to being stopped and searched, being overlooked for promotion at work, being bullied, being harassed. It relived all these kind of traumas. And so it raises lots of issues about what do we need to do, not just simply about having good inpatient care and all that kind of stuff, but the wider societal issues around structured racism and its impact on our psyche, on our mental health, on our well-being. So these are kind of big questions that we need to explore, and the question that we need to ask ourselves is, how do we respond to that on an individual basis in terms of our own self-care and resilience and survival? How do we respond to that in terms of services? And back in the day, and there was at least 100, 200 organisations, projects, charities delivering mental health care in the black community. Black run, black led. Lots of them were under-resourced. Half of them never really got commissioned by the NHS. Some did, not all did. But there was a need there. Those organisations have virtually disappeared. I don't know how many black-led organisations are now left in the UK, and I don't know if there are any in Hertfordshire, by the way. Has there been a history in Hertfordshire of black-led mental health charities or support groups, etc. But they played a key role for some people. I mean, I'm very lucky that I'm a patron of one organisation called ACCTI. It's been going for about over 35 years in Wolverhampton. And it's it provides a range of support. It's got a day centre, it's got a supported housing scheme, it does counselling, and it does a lot of work of community outreach as well in the community. So, but that is a luxury, and it's in Wolverhampton. In London, there's hardly any black-led mental health services I've come across over the last couple of years. There was one initiative I was involved in as director. I was director of Black Thrive, but that's more of a partnership approach around tackling mental health and well-being. They're not really service provider, but I'm talking about service providers. So that is an issue. We need to have a mixed economy. Yes, the NHS is critical. it has a role to play, and especially as taxpayers and citizens, we want to make sure that local NHS mental health services meet the needs of the community. But also we recognise that the NHS can only reach so far. There is still a fear factor for Black people going to mental health services. The groundbreaking report, Breaking Circles of Fear, which was done in 2002, though if I was to delete the date, the recommendations of that report is probably no different to what is required even today. How do you break the circles of fear? Black people are fearful of going to mental health services, and at the same time, the services are fearful of Black people. How do we break down that cycle? Because and there might be individual cases where that cycle has been broken, and that's fantastic. And I've met people who have been able to break that cycle, but yet for the vast majority of Black people in the system or out of the system, it's still an issue. It really is. I know that there was the mental health task force. Sir Fred Wesley chaired a task force looking at reviewing the Mental Health Act. Came up with a number of recommendations, which the government are consulted on, and are looking to implement that in future legislation. And there are some aspects of that Mental Health Act reform I commend and useful, but it completely missed the exam question. Never explored how do you tackle or decolonise mental health services. I mean, that wasn't the exam question, but that's the issue that everyone needs to explore, to be quite honest. If we can have these conversations around decolonising museums, archives, national curriculum, I haven't heard these conversations in mental health services or the wider NHS. If you've heard that, let me know, please. I know there are individual conversations, because I'll give a good example. When after the murder of George Floyd, I got invited on the NHS England BME network. There were about 500 staff, and all the staff started to share their experiences about discrimination, bullying, harassment. It was almost like the murder of George Floyd gave people permission to talk about these experiences. So I think the key issue and what is important is there's lots of system change happening around mental health services and commissioning of mental health care. We need the voices, and obviously doing my bit, but I'm just one voice. But we need the voices of the community to now get involved, to be part of this conversation and dialogue, to ask relevant personal questions around the types of care that their family members are receiving, the types of care and services that are available around choice, and the types of prevention measures and intervention measures to stop people getting into the system in the first place. These are kind of some of the big questions we ask ourselves. And on top of that, a growing recognition that there is something called anti-blackness or Afrophobia, where it's quite clear. We knew this already, but because we use the word BAME, it gets hidden. And I mean, everyone knows about the Sewell report. I'm not going to go into the Sewell report. That's another separate conversation, and life is too short for me, to be quite honest. But there's at least one thing about the Sewell report. It said that the word BAME is a problem, and it is a problem because when you use the word BAME, you mask lots of communities, different experiences of race discrimination, and they mask intersectionality. So if you're a gay Black man, if you use the word BAME, you're hidden. Or a trans woman, it's hidden. So that's why we have to kind of uncouple this and to explore, well, who has been impacted the most around the impact of race and discrimination. So these are kind of things that we need to kind of explore and tease. But also on the positive note, we have to acknowledge and still celebrate what we do. Black History Month was created, and I think people have forgotten why it was created. It wasn't created to have parties, and it wasn't created to talk about EDI. It was talking about Black people and acknowledging our achievements, our history, and a sense of racial pride. That was the concept that was created by Councillor Woodson in 1926. That was a concept that was created in 1987 for Black History Month. And yes, it's great to talk about EDI and strategies, but it's not about that. It's about Black people saying, we survived another year. Let's celebrate our history. Let's celebrate our history. Let's acknowledge that we are kings and queens, and we are proud to be Black. I'll stop there.
Patrick, thank you very much, Patrick. A lot has been packed into that, and I think we'll probably take a whole other session to unpick everything that is there. Thank you very much indeed. I'm not going to get into the issue of the BAME stuff, because I think that's a debate that's probably going to run and run. I do think, though, that your point about the structural and systemic issues that I think the Sewell report ignored are things that are just as prevalent, as you've said today, as it was 20, 30, 40 years ago. After all, however, enough said. Time is moving on. So I'm going to actually now introduce our next speaker very quickly, and that's Hollis Dixon, who's one of our EBEs. Hollis is going to tell you something briefly about his journey and so on. So thanks, Patrick, and I hope you're going to be able to stay with us, but
Sure.
Over to you, Alex. Hollis.
Good evening. Can everybody hear me all right? Is that okay?
Yes.
Yeah. I haven't got long, so I can't really go through my history, because my history sort of pans over 25 years. So in 1996, I was diagnosed with psychosis. This was said to be then a drug-induced psychosis. Between that time and 2006, the services I received was very limited. There was no therapy, there was no interaction, there was no questions answered, no guidance up until 2006. I did work through that period of time. 2009, I was homeless, 2009, I was homeless, I became homeless. And I was homeless for 3 months. I thought, and I still believe now, that I was of sound mind at that point. Even though I was homeless, I was looking after myself. The services got involved again, and I was detained, I think, because of my living conditions, not because of my mental state. So I was detained then, and I was in hospital for 3.5 months. The diagnosis at the end of that detention was schizophrenia. So 2009, when I actually left the services or discharged from hospital, I got involved in different charities for, recovery and to build up my confidence and things like that with Mind, Viewpoint, and then I went on to HPFT. I want to go back to the diagnosis I received in the outset. Through my work with involvement work with EBEs, I've learned that 75% of Black males who are diagnosed with any mental illness is either psychosis or schizophrenia, and this is across the board. So if you think about the stigma attached to schizophrenia, it's a lot more damaging to a person's social status, basically. If you know of someone with schizophrenia, the first thing that comes to your mind is not of the same as someone with depression or bipolar, which is very similar, but the name schizophrenia, it drums up a different picture of a person. So therefore, that stigma and that belief or the perception of your diagnosis is a hampering of your life from then on. So 75% of Black males, as you mentioned in Hackney, I think you were talking about, Patrick, they are psychosis or schizophrenia. So therefore, they are hampered from the beginning from that diagnosis. That's what I've realised. So after I was discharged, I went into volunteer work with Mind, and I've done art and poetry, which I actually learned in hospital, or I took part in hospital, which I've written 3 books, in fact. I've done X amount of exhibitions when it comes to my art. My art actually got me involved with the HPFT, because my first sort of large involvement was the BAME conference with HPFT. One thing what I left that conference with is, why have they got a BAME conference when they have a general conference? Why aren't they together? I left with that in my head. They shouldn't be 2 conferences for the same issues, basically. They should be together, working together. So, and this was 2013. I worked through HPFT doing a lot of involvement, and I didn't get involved with the BAME network for the simple reason that they shouldn't be separate. I believe they shouldn't be separate. I believe everybody should work together for one common goal. I'm not putting my head in the sand saying that there's not things which separate, but just the name BAME itself separates. I did do it was a psychologist presentation to do with diversity and equality, and they were setting out different parameters within the social graces and things. And one thing that came to my mind is BAME, which is, you know, Black and ethnic minorities. Is there a group anywhere in the world, whether the native people of that country is Black, white, Indian, Chinese, whatever, is there one what says white and ethnic minorities? Okay. It sort of, that stood out to me, as in it's a social problem. It's a society's problem. It's something which people have got used to and accepted, which doesn't really gel. It doesn't make sense. It's illogical.
Okay. So, Ollis, I think, bearing in mind time, we're going to have to stop you, dear. Thank you very much for that, and for sharing your journey, which is really quite important. I know you're going to be with us, so there may be some questions later on for you to answer. So I'm going to move on, because you've been talking to services. So I'm going to ask Dr. Mosun Fopahunda to now speak to us around accessing services.
Good evening. Thank you for that introduction, Clive, and thank you, Patrick and Hollis, and all the other speakers on the forum, and everyone that I have an opportunity to talk to tonight. So I'm going to share a few slides. I would go through them quickly, because I know that so if I can't, can you see my screen?
Not yet.
Not yet, okay. You able to see my screen now?
Yes.
Yes.
Okay.
But I think you are probably not. Are you showing the first slide? I think you.
From beginning. Can you see my screen now?
Yeah, can, yes.
Yeah. Okay, thank you. So I'll move through quickly, because fortunately, Patrick and Hollis have already said most of the things on my slides. But it's important to talk about accessing the service. So I'm a consultant psychiatrist. I work with HPFT. Just a bit of a definition to show WHO defines health as a state of complete physical, mental, and social wellness, not just the absence of disease and infirmity. So for you to really be well, you need to be well mentally, physically, and socially. And just a bit about mental illness. We all know it's a serious disorder that affects our thinking, emotion, and behavior. Affects 1 in 4 of the population, according to WHO figures, and it can affect anyone, any gender. We all know stigma still exists, as well as health inequalities relating to mental health. And I think Patrick said a lot of that. But in managing mental illness, as with any other diseases, prevention is very important. And that's why we encourage people to present early. Early intervention means that the outcome and the prognosis of the illness will be better. Obviously, we'll treat and manage. And then some people may require long-term follow-up if they have a severe and enduring illness. And obviously, the severity could be mild, moderate, and severe. And the management plan also would follow the severity. In getting access to services, and because we're talking about Hertfordshire in particular tonight, there's so many mental health charities and organizations. And I think Patrick had mentioned some of this as well. So just go to Google, Signpost, Women's Center, Home Start, Hertz for Men. There's so much, Hertfordshire Network. There's so much out there. You know, Viewpoint, Combat Stress, online, telephone, face-to-face. So young minds, for all age groups, there's so many helplines, apps that we can use. So just to bring that to our attention as well, if you need immediate support or you want to chat with anybody. But in terms of structured services within primary care, you'd have your IAP services, the mental health wellbeing teams. You can contact your GPs. Some GPs have mental health workers that work within the surgery. And of course, we have the enhanced primary mental health care service, which bridges the gap between primary and secondary care. And secondary care, I'm using HPFT as an example in Hertfordshire. We offer a range of services, covers all age groups, child and adolescent, early intervention, community services, if you require inpatient care as well, older adult, learning disability, eating disorders, mother and baby. And obviously, if you were to be admitted into the general hospitals, Leicester Hospital, Watford General, and the rest of it would have the mental health liaison teams as well that can support you. So there are barriers to mental health care, of course. We've talked about some of them, and even the NHS Race and Health Observatory released this slide on the left-hand side, which just mentions one of the mental health inequalities that we have, with Black people more likely to be managed under a community treatment order. But there are various factors that can, be barriers to mental health. We talked about stigma, we talked about fear, lack of trust. I think we've mentioned that as well. Some people having negative experiences of mental health care and not wanting to go back. Language barriers, socio-economic factors. There's some internal factors, personal factors, societal factors, systemic factors. So there's some personal factors that could be due to religion and culture that may make people not present on time as well. And we know about some of the things, the data we have about mental health equalities in Black people and BAME as a blanket figure. So like Blacks being more likely to be admitted to a mental health ward, disproportionately subject to community treatment orders, use of mental health as compulsory detention, Black groups seeking mental health support later rather than in comparison to other ethnic groups. Lots and lots of efforts have been done. Research, institutions. I mean, I won't go through all of this because Patrick has mentioned some of them. So there's ongoing work, there's policies, there's reforms, mental health trusts, Royal College of Psychiatrists, the King's Swan, Sainsbury's Centre for Mental Health. There are lots and lots of research going on. We know that we still need more of this. But the change factors that I think are important is, I'll describe 4 factors. One is for us to continuously attempt to know our population. So maintaining dialogue with our population like we're doing tonight, and building meaningful relationships, understanding and improving the population data. So if we get that right on the social front, and we know the percentage of Black people in that environment, Asians, that can help you with your service provision as well. Organizational leadership to make the changes obviously is important because change will not just happen. Then improving access to co-production is trying to make it easy for people to access the service, population knowing what support is available, which is why one of the reasons why I'm happy that we're doing this tonight, so we can tell you what's available, and ensuring appropriate access routes. So irrespective of where you are, at home, online, telephone, general hospitals, your GP surgeries, you can get support. Support can come to you at home, the ambulance, the street triad teams. So it's early intervention and early presentation is really important. I can't overemphasize that. So improving experience through co-production, culturally adapted, personalized, patient-led care, it's very, very important. So you're not misdiagnosed. So people don't take your cultural beliefs to mean that you're psychotic. You know, staff training and development is very important. So people have an understanding, they're culturally competent, and they have an understanding of how they can best support you. Developing care collaboratively with the community and voluntary sector. And I think that's one of what we're doing tonight. Asking people about their experience. So that feedback is really important for our service users, from our service users. Obviously, to measure outcomes as well, collaboratory agree outcomes for the person, continuous learning and development, you know, just improving collaborative working and understanding of what we need to do. So just 2 more slides now, how to get help. You can use mental health apps, you can ring 111, lots of third sector organizations have shown you. If acute, urgent, and you're really worried, obviously, you call 999, ambulance, street triage. If you're within the general hospitals, you have the mental health liaison teams. Within the primary care services, you have your GP, you have well-being services, you have nurses based within the GP surgeries as well, mental health nurses that can help you. And obviously secondary care services, like I've shown you about the services we have in HPFT. So I know we're using the opportunity of the Black History Month to celebrate, collaborate, learn, improve outcomes as we're doing tonight, but it's also important that we ensure that these efforts are all year round and not just limited to October when we're celebrating the Black History Month. So thank you for listening.
Thank you, Mohsen, for that comprehensive review of what's available. We're going to come back to that in a little while, but I'm now going to just pass on to Annie in the interest of saving some time, and we can come back to the questions in a minute. Annie, about involvement, engagement in the mental health services. Welcome, Annie.
Thank you. Hello, everyone. My name's Annie Bankole Race. I am here with 2 hats on. I'm a governor at HPFT, and one of our responsibilities as governors is to be ambassadors for the trust. And one of our responsibilities as ambassadors is to encourage people to get involved. And so I'm here to talk very, very briefly about engagement, involvement, and for me, particularly representation of people of colour with mental health services. I'm going to use as a springboard something that Patrick said earlier, which was about the disconnect between the improvement in medication, addressing mental health issues, and a lack of visible impact on the population he sees on the streets of Hackney. For me, that really struck a chord. And there is a lot of complaint, and some of it is justified in Black communities about how the services that we receive are not geared towards us, don't take into account the realities of our lives, don't take into account so very many nuances of the lives of Black people in the UK, of, you know, what we go through. And that is true. But I also have a countervailing argument to that, which is, if the people designing the services have no understanding of the people, of a significant proportion of the people they are designing these services for, how can they then design the services for them? And the only way they can get that understanding is if we, members of that significant proportion of the demographic, actually get involved. If we put ourselves forward, if we get involved, then we can make a meaningful contribution at all levels, whether it be, you know, and I don't disregard any kind of involvement. Involvement is at all levels, whether it's as a volunteer, whether it's as a member of HPFT. As a member, you have a voice. You can, you know, you attend AGMs. You're a member of the trust. As a volunteer, you are there actually working in the trust. You are making meaningful, you know, actions. As an expert by experience, you are using your lived experience to shape the services. You, as a member, you can stand for governorship. You are then in a position, in a decision-making position. Governors make decisions about remuneration of NEDs. Patrick, close your ears. And the CEO, they decide on appointments. They sign off on the finances. Governors have, you know, they're the critical friend to the board. That is real power. You know, so if we don't put ourselves forward, if we don't get involved, how can we then say they're not listening to us? For me, I think that we need to be involved. I'm incredibly passionate about this. I'm a service user. And people say, well, how can you, I'm an African, and Africans on the platform will understand that it is not an easy thing for an African woman to stand up and say, hey, mental health, mental illness, ill health, you know, waving her hand here. The stigma, the societal opprobrium is immense. But if we allow that to hold us back, we will never move. In order to move forward, in order for any kind of progress to happen, we've got to destabilize ourselves. Sometimes that destabilization comes at a cost. It might be a personal cost, but in order for the greater good, something has to move. My plea to everybody is, please find ways of involving yourselves at whatever level you can. It's not for me to say, oh, people should be this, but involve yourself somehow so that we can actually make meaningful impact in the trajectory, in the direction we want services to go. So that we're not in 10 years time. At the moment, I also wear a number of NHS hats. And I know that the NHS at the moment is trying very hard to involve people of, you know, of all colors, of all shapes, of all perspectives in shaping the direction the NHS goes as much as it can. And I would like to believe that we're taking that opportunity so that in 10 years' time, we're not having these same discussions. Patrick isn't seeing the same vista on his road. I'm not, you know, making the same, because this is, I'm pleading basically, saying, please, if you live in Hertfordshire, become a member of HPFT, join your local organisations. There are all sorts of organisations. It doesn't have to be Viewpoint. It doesn't have to be Monday. You know, start off a local, you know, community organisation, anything, but let us get involved. Let us actually make our what's the word? Our presence felt. So that when we say that things aren't going our way, we're saying it because we've tried, okay, and not because we expect manna to fall from heaven.
Thank you very much, Annie. As excellent points there regarding us needing to engage. I often say in conversation that if you're not part of the solution, you're part of the problem. Thank you very much for that. I'm looking at the time, and we've had some important contributions. Regardless of anything else, I do want to make sure that we hear your voices this evening. However, I think we did have a section for some questions. I can't see any questions in the chat, but does anyone have any questions they don't want to raise now? Otherwise, I'd actually go into the group process so we can hear your voices to look at where we go from here. Any questions that anyone, just raise your hand or press the hand button. Well, it sounds like I'll speak. Oh, Prab, brief question, please, Prab, because we are going to want to move on.
Yeah, thank you, Clive. I think I've heard most of the thing, and I like what I've heard. In terms of involvement, the question is my experience over the years being involved in a lot of other governing and trustee kind of positions is perhaps we're starting off on a back foot. One of the things I've kind of tried to champion in terms of making our involvement meaningful is actually to be empowering people to be able to make that impact on the bodies that they sit on. Most often people are not equipped to make that difference and often get kind of victimized, channeled into this minority kind of thing. He's only going to talk about race relations or the, the need for people to be represented. So I think there is that empowerment role, and how can you go about doing that?
Absolutely. I'm not going to ask for a response to that as yet, because I think we need to maybe talk about that in the next exercise, because I think a really important point that you've raised there. Caroline, did you still want to ask a question? I think you've taken your hand down. Yes, you're muted at the moment.
Yeah. Okay.
Very brief, as I've said.
I just wanted to ask, proportionately, do we know the percentage of people in this society, in our society, in British society, who suffer mental health? And can that be compared with, let me rephrase that, people of African heritage? And can that be compared with people of African heritage in Africa and in other parts of the world, in the diaspora?
Okay. Good question. Patrick, I'm not sure if you know the answer to that question. I don't know the answer to the question. Does Mohsen, do you know the answer to that question? No. Patrick?
So in terms of people suffering from mental health, there's lots of, say there's 1 in 4, 1 in 3 of the population at any one time can suffer from mental ill health. In terms of the data, the government website, the Race Disparity Unit, they looked across 18 government departments and they looked at data around inequalities in society. Simon Woolley was a chair of that, and they had data connected with mental health. So if you looked at psychosis, it was. I think you have to add there's a health warning with some of these data sets, if you want my honest opinion, because the way that ethnic coding is not working properly in the NHS. But if you looked at the data that was produced on psychosis, it was, particularly for black men are 8 times more likely to suffer from psychosis than the average population. If you look at ordinary common mental health problems like anxiety, depression, black women and Asian women were probably 3 times more likely than white women to suffer from that. Back in the good old days, what was around the DRE program was a government program that lasted for about 5 years, or under 5 years. There was the Count Mean survey, and every NHS mental health trust had to produce that. It was like an audit once a year on a day, and that report, which is produced, highlighted the overrepresentation of black people as well. The Mental Health Act Commission, which is now part of the Care Quality Commission, did audits and reports. So there's lots of data and even within our trust, I think with Hertfordshire Trust it's a bit different because we haven't got that massive black population, but other trusts in major cities, you just have to go in the inpatient care wards, and you'll see out of every 10, 20 beds in a ward, at least 50% are black men. So, but if you look at internationally, it's interesting. It's a different story. And one of the key issues is around the whole stuff around that. If you talk to academics, and there are quite a few in the room here, that the impact of migration does increase people's experiences of mental health, basically. And but if you were to look at the Caribbean population per head and the African population per head for mental illness, it's quite low. It's not, but if you look at America, Brazil, and here in the UK, and also in France, why is it that so many black people overrepresented compared to the average population in those respective countries? That is a big question.
Okay, thank you, Patrick. I'm going to, because of time, I'm not going to, I'm just going to take one other question, then we have to move on. Cedric, you wanted to ask a question.
Yeah, thank you. Very quickly, two questions in terms of in response to the previous speaker regarding engagement. We're very small as a population. I'm based in London, and I know that one of the challenges is that sometimes when you sit on boards or want to sort of apply for trustee roles or just want to get involved actively, sometimes you're the only black individual in that room and on that table. And I think we need to somehow find a way of whether it's kind of through our own sort of networks, but a way of auditing and managing and supporting those individuals who are on those individual boards, so that we have some kind of network ensuring that you're not feeling on your own in these spaces. I think it's important. I agree with you wholeheartedly that we should be part of the conversations, but we are also very much a minority as well, and our own personal well-being also matters, and sometimes that can be damaged when you sit on these in these boards. But also, more importantly, just wanted to pick up on sort of some of the comments that people are making regarding African and Caribbean community. We need to be very careful that we also don't fall in the trap when we talk about African communities, because that is also a very wide diaspora. And also within the Caribbean community, we need to be slightly more specific when we talk about Black Africans who are more likely to be sort of in mental health services. Which group are we talking about? As well as Black African Caribbean men. Which African Caribbean men are we talking about? I think we, as a community, just need to be very careful in adopting the language of simplicity when we describe our community. Thank you.
Thank you very much. A point well made, which of course probably does go back to this issue of the names that we call ourselves. I think names have a purpose in certain circumstances, but we also have to recognize that there are sometimes distinct set of experiences that we also shouldn't ignore. But I think we can be very simplistic about this in all sorts of different ways, because we, when it comes to the experience of racism, there are some commonalities between some different groups of people. Yet there are also some very distinct experiences that particular groups of people will have. So I think we've got to find a way of doing this. So saying we don't do one thing and we do something else isn't necessarily a solution. I think we have to do a combination of different things. Thank you very much, Joe. I'm just conscious of the time, and we were scheduled to finish at past. At a point now it's 26 minutes past. Now, I really do want to hear the voices of the people that are here. So I wonder if I could crave your indulgence and say that we're actually going to have a little bit of group exercises we've planned, so that you can actually have a consideration of the key points is where do we go from here, really, as the question that you may have seen on the program was really kind of just thinking about what needs to change to ensure an accessible mental health service for our community, despite the fact that it's a simplistic definition. And it may be, and what's in my mind in relation to this is what needs to change for the individual, what needs to change for the community, what needs to change for services. So I'm going to ask you, maybe we'll just give this 10 minutes for people to go in groups to think about this. And what I'll do is I'll actually pose this in the chat. Very briefly, the way it works is that there's an automatic process. I'm going to ask you to go into these groups once I've sent you into the group. I'm not going to make it too many. What we will do is ask you just to consider those questions and to identify maybe one thing that we need to focus on as individual, one thing as community, and one thing as services. And if we can put that in the chat at the end, because we're not going to have a formal feedback, then we'll try and finish off as quickly as possible. So I'll put a question in the chat, but I hope that makes clear. But I'm not going to waste any more time. I'm just going to put that in there now. So Adrian, we can stop sort of recording just now.